Good afternoon. We're presenting today Professor Georg Lenz. Professor Georg Lenz was educated in the University of Nuremberg and University of Berlin. He started his professional career as an assistant physician, which was in München. Then he had been trained in the NCI in the Bethesda, United States of America. Then he started his professorship actually in 2014 in Hospital of Munster, after which he was appointed in 2017 as the director of the Department of the Internal Medicine in 2017 in the University Hospital of Munster, after finishing his training in the Charity Hospital and being the senior leading physician there. He was awarded a lot of awards during his career. Also, he is the head of the aggressive lymphoma group at the German Lymphoma Alliance. And he is the founder of the Cells in Motion and professor of translational oncology. Our Professor Georg Lenz, will speak with us about the German trials for aggressive non-Hodgkin lymphoma and the updates in the treatment of the aggressive non-Hodgkin lymphoma.
Thank you very much for the very kind words, and obviously the invitation to give this presentation. It's a great honor. I obviously would much more like to be with you in person, but still these are crazy times, at least in Germany, and therefore this time only virtually. So I will be talking about aggressive lymphomas. I will specifically talk about diffuse large B-cell lymphoma. When I prepared the talk, I thought it might be interesting if I just give you an update how, at least in Germany and probably also in many other countries, we treat patients with diffuse large B-cell lymphoma. And I will also, from time to time, give you the German perspective, especially with an emphasis on currently recruiting or planned German trials. So these are my potential conflicts of interest. However, they obviously will not in any way influence the content of this presentation. So what is the standard procedure in DLBCL? We just currently wrote the current guidelines for Germany. These are the DGHO guidelines, which we published, which at least at this stage are still valid. And as you can see, obviously it's in German, but I can translate that to you. Standard of care for the vast majority of cases is 6 to 8 cycles of R-CHOP chemotherapy. For elderly patients, you might decrease the intensity of R-CHOP to R-mini-CHOP, or, which I would not generally recommend, despite the fact that's in the current guideline, is to change to R-bendamustine, because R-bendamustine is able to induce in roughly 40 to 50% of patients a response. However, these responses are currently not, or are often not very long lasting. However, I think R-CHOP for everyone is correct, and if an American speaker or someone from the UK would give that presentation, then that probably would be the message. I think, at least in some parts, we can see that a little bit more, or can see that a little differently. So I think we can distinguish subgroups of patients with diffuse large B-cell lymphoma based on the International Prognostic Index, as you all know, which categorizes diffuse large B-cell lymphoma patients according to their age, according to the manifestation of extranodal sites, LDH, performance status, yes, and these are the 5 factors. So we can distinguish young patients, young is defined younger than 60 years of age, with a low risk IPI, so having 1 or 0 IPI points. The second category are young patients with a high IPI. This is an age-adjusted IPI of 2 to 3. And we have the elderly patients who are older than 60 years of age. So what are the current recommendations for these patients? Starting with a young patient with a low risk IPI, I think for patients with one IPI point, you can do what probably most of us will do. You give them 6 cycles of R-CHOP chemotherapy based on the so-called MINT study from Michael Freund, who published 15 years ago in Lancet Oncology. And you can see, I hope you can see my pointer, that we can cure with this approach roughly or more than 90% of patients. For the very low risk patients who are younger than 60 years of age and who do not have any adverse factor, no IPI factor, no bulk, I think we can further decrease therapy. This is based on the FLIER study that has been published in the meantime in Lancet. So in this study, which was performed in Germany, 6 cycles of R-CHOP as standard of care were compared to 4 cycles of R-CHOP plus 2 applications of rituximab. These are the results. The primary endpoint, you see there's no difference in PFS, no difference in overall survival. And I'm not showing this, however, significantly less toxicity, which makes sense for the regimen with 4 cycles of R-CHOP plus 2 applications of rituximab. So to me, this is the new standard for patients from the age of 18 to 60 years of age with no IPI risk factor. So what's the standard of care for young patients with high-risk IPI? Is specifically, because we use that a lot in Germany and also in some Nordic countries, is the role of etoposide. So when you have a young patient, again defined being younger than 60 years of age, you can cure with R-CHOP, and having a high IPI, you can cure roughly 50% of the patients, so not a very good standard. So does etoposide add anything? So this question is not fully resolved, but I want to show you some data from German trials. So a couple of years ago, and this was published almost 10 years ago by Norbert Schmitz, who actually also works in Münster now, and they compared as a standard, which wasn't really a standard, I have to say, 8 cycles of R-CHOEP, so CHOP plus etoposide, versus the so-called mega-CHOEP regimen, which is very intensive, very high dose CHOEP regimen, and it's so highly dosed that you need 3 autologous stem cell transplantation. This is the follow-up that we just recently published in Lancet Hematology. You can see the 2 curves, and there is no significant difference. However, I think there is a trend that the R-CHOEP is superior to the intensive chemotherapy. And the major point, however, is when you look at the survival curve, you can see that more, and this is a follow-up after 10 years, that after all this time, still more than 70% of the patients are alive. So this is very, very good compared to the historic comparison of 50% following R-CHOP. So I think etoposide has some value. However, we have never shown that in a randomized trial, R-CHOP versus R-CHOEP. So what trials are currently running in Germany? We know from the Phoenix trial, and I will not show the data, and this was a trial that incorporated R-CHOP plus the BTK inhibitor ibrutinib. In this trial, while it was formally negative in the younger patients, there was a significant increase in overall survival of more than 12%. So we are currently testing our CHOEP regimen plus rituximab plus ibrutinib in high-risk IPI young patients. This study is ongoing, but it's almost fully recruited, so can hopefully show the results very soon. So what about the elderly patients? Elderly means 60 years, more older than 60 years of age. So in elderly patients for years, there were 2 standards. This was one, the standard by Bertrand Coiffier defined and published in the New England Journal of Medicine almost 20 years ago, R-CHOP, 8 cycles, R-CHOP 21, and as you can see, is obviously better than CHOP alone. However, there was a second standard, I'm not showing the data, which was also quite good, which was 6 cycles of R-CHOP 14 plus 2 applications of rituximab. This was the German R-CHOP 14 regimen, so to speak. And there was a lot of debate if you really need to shorten the interval of R-CHOP from 21 to 14 days. And to answer that, various randomized phase 3 trials were performed. I want to just show you some of the results. And this is a study by Delarue, and that was performed in elderly patients, 60 to 80 years of age, and you can see no difference between R-CHOP 14 and R-CHOP 21. And this was confirmed, I'm not showing the data again, by the Cunningham data study that also compared in all patients from 18 to 80 years, R-CHOP 14 is not superior to R-CHOP 21. So what is my recommendation here? I think R-CHOP 21 is completely fine. If you treat R-CHOP 14, or if you use R-CHOP 14 in elderly patients older than 70 years, there's a lot of toxicity. So I would really discourage from doing that. Then about R-CHOP 21, do you need really 8 cycles? I think the answer is no. There are many comparisons that compared 6 cycles to 8 cycles, and there was no difference. So I believe that if you don't cure a person by 6 cycles of R-CHOP 21, it probably will not work with 8 cycles either. So I think an internationally accepted standard is 6 cycles of R-CHOP 21. So are we currently having a trial for this segment? Yes, we have that so-called COPPA R-CHOP study, which is a first-line therapy study for patients with 18 to 80 years of age with an international prognostic index 2 to 5. This is a phase 2 trial where we investigate the value of R-CHOP 21 plus the PI3 kinase inhibitor copanlisib. So why copanlisib? We have some phase 2 data that in relapse refractory patients, copanlisib in certain subgroups, especially of the ABC subtype, works quite well, and therefore we're testing the combination of a PI3 kinase inhibitor plus R-CHOP therapy. However, when we talk about R-CHOP, I think we also have to at least mention that the standard of care might change in the very near future. So there's the POLARIX trial, and I'm sure many of you heard of the POLARIX trial. This is a study that has been fully recruited approximately 2.5 years ago, now in June 2019. And this study tested the value of polatuzumab vedotin in first-line therapy of diffuse large B-cell lymphoma. So what is polatuzumab vedotin? It is an antibody-drug conjugate, and an antibody is directed against CD79B, which is expressed specifically on B cells. So in this trial, patients with 18 to 80 years of age with an IPI of 2 to 5 were randomized either in the standard care arm, R-CHOP plus placebo, versus R-CHIP. So this is a CHOP without vincristine plus polatuzumab, and followed by 2 cycles of rituximab. So we don't know the results yet. However, we have seen the press release, and the press release showed that polatuzumab plus R-CHIP is superior with respect to the primary endpoint PFS compared to R-CHOP. So it's tempting to speculate that R-CHIP plus Pola will be the standard of care for these patients. In the future, we'll see the data. So the manuscript is submitted. The data will probably be presented at the upcoming ASH meeting in December. So we will see if the standard of care will change very soon for the frontline therapy of diffuse large B-cell lymphoma patients. So what about relapse refractory patients? They are, first of all, characterized by adverse outcome. We still need much better treatment algorithms for these patients. And up to now, and I will show you some data that probably this will also change in the very near future, we distinguish patients that we can do a transplantation on versus the transplant ineligible patients. So why transplantation? This is something we have been doing for quite some time. And this is based on the work by Philip and colleagues published in 1995 in the New England Journal of Medicine, in which they compared conventional treatment versus high-dose chemotherapy and transplantation in aggressive lymphomas. However, some comments about this study. So these were not just DLBCL patients. These were all kinds of aggressive lymphomas. None of these patients were treated with rituximab, which is standard of care today, obviously. And the third important point, obviously, our supportive care dramatically changed. So it's really unclear if these results hold true in the rituximab in nowadays era. So what do we know about the efficacy of autologous stem cell transplantation in rituximab treated patients? It's not very good. And this has been shown by the Corral study published by Gieselbrecht and colleagues in the JCO. And you can see if someone relapses after treatment with R-CHOP within 1 year, you can only cure 15% of your patients with an autologous stem cell transplantation. So very poor outcome. To improve that, a trial is currently running in Germany that tries to improve outcome of transplant eligible patients. This is the so-called POLARIZE study. So what is the POLARIZE study? It tests the conditioning regimen or the induction regimen ICE versus the combination of ICE chemotherapy plus polatuzumab. So the hope is to add polatuzumab and therefore improve outcome of patients, to get more patient into good remission, to get more patient in remission, and then more cure patient by autologous stem cell transplantation. So this is an international driven study sponsored by Roche, and obviously we will see how these results pan out. However, also here, the standard of care might change in the near future, because there were 2 studies, actually there were 3 studies, but 2 were positive, that tested in high-risk DLBCL young patients autologous stem cell transplantation versus CAR T-cell therapy. And BMS and Gilead Kite reported a press release again on the Transform study, respectively the ZUMA-7 study, and they reported that the outcome is positive. So CAR T-cells seem to be better than autologous stem cell transplantation, and this will dramatically change the therapeutic regimens, because probably will not do transplantation anymore in high-risk patients, but we will use CAR T-cells very early. So again, a change of practice probably will happen very soon. What about third-line therapy? I just talked about CAR T-cells, and therefore it's logical to show you CAR T-cell data. So what are CAR T-cells? I'm sure you're all aware of the principle. So you harvest T-cells from the patient, you genetically modify them that they attack a tumor-specific antigen, and there are currently several approved CAR T-cell products, and they all attack the B-cell specific antigen CD19. So what about efficacy? I want to show you the data for both the Gilead Kite and also the Novartis construct, starting with ZUMA-1 data from Gilead Kite. In this study, patients with relapse refractory disease with at least 2 prior lines of therapy with either DLBCL, primary mediastinal B-cell lymphoma, or transformed follicular lymphoma were treated within the ZUMA-1 trial. These are the response rates of patients receiving CAR T-cells. You will see response rates in the ballpark of 80%, with a high degree of complete remissions shown in blue. And these are the long-term data, the median duration of response. There's clearly a plateau. Interestingly, there's no difference, at least in this trial, this is different in other trials, between patient in CR and PR with respect to progression-free survival. This is the progression-free survival of all patients. Again, you can appreciate that there's a plateau. So obviously we are curing patients with this approach. And this is the overall survival curve that shows that somewhere in the ballpark, I would say between 30 and 40% of all patients probably are cured. I have to say, obviously, with all studies, this applies to all studies, we have a selection bias. So not everyone qualifies for CAR T-cells. Not everyone gets into a remission, which is very important, before CAR T-cells. So not everyone really benefits from CAR T-cell therapies. However, these data clearly show this CAR T-cell therapy has a curative potential. So a very efficacious therapy. And then I want to show you the data that have been shown at numerous congresses and published by Stephen Schuster in the New England Journal of Medicine on the efficacy of the Novartis construct. In this trial, again, patients with aggressive lymphomas were treated. Here you see the duration of response, and this, at least to me, is not so surprising. For patients in a complete remission, duration of response is better compared to all patients, and especially the progression-free survival, and again, the overall survival is better for those patients achieving a complete response. But also these data show that, again, similar to the Gilead construct, that CAR T-cells are curative in some patients with relapse refractory aggressive lymphoma. So what about novel approaches? So how will we treat patients in the future? I want to give you a couple of examples, starting with tafasitamab. So what is tafasitamab? Tafasitamab is an anti-CD19 antibody with certain effects on the tumor cells. So when we use tafasitamab as a monosubstance, roughly 25% of all patients respond. So this is not that great, but when you look at duration of response, the duration of response is in median 20 months. So patients who respond, they normally benefit for quite some while from this antibody. So tafasitamab has been approved in the US and both Europe based on the so-called L-MIND study. So what was the L-MIND study? It combined, based on preclinical efficacy data, the anti-CD19 antibody tafasitamab plus lenalidomide. And the tafasitamab was given until progression, and the inclusion criteria important. Patients that were transplant ineligible, that were treated with 1 to 3 lines of prior therapies. However, no primary refractory patients were included, and no double and triplet patients with double and triplet lymphomas. So definitely a selection for good risk patients. These are the response rates, very good, 60% with a CR rate of 41%. And when you look at the duration of response, it also looks very, very good, with a median duration, at least in this analysis that was presented at the EHA meeting last year, of 35 months, so almost 3 years. So if patients benefit from this regimen, they benefit for quite some while. The positive aspects are it's very well tolerated. It's a different approach. So if you have a chemo refractory patient, there's a switch in your mechanism. So this is, I think, a good aspect. So the very interesting regimen. So what about the very near future? The bispecific antibodies. I'm sure you heard a lot about bispecific antibodies. So what are bispecific antibodies? Antibodies that have 2 binding sites. So they bind frequently CD3. What is CD3? It's an antigen expressed specifically on T cells. And on the other side, the bispecific antibody binds a tumor-specific antigen. In this case, I show you the data for blinatumomab. It binds CD19. So CD19, as you all know, is a B-cell-specific antigen, and blinatumomab has been used and is approved for the treatment of patients with relapse refractory ALL, and there it's very efficacious. So what are the data for aggressive lymphoma? So we know since years, and I think this is an underappreciated manuscript by Goebler and colleagues, where they tested in a phase 1 the efficacy of blinatumomab in relapse refractory lymphoma patients, and among others, patients with diffuse large B-cell lymphoma. And you can see from this chart that some of these responses are very long lasting and still ongoing. And when at a certain dose level, more than 50%, or more than, I even believe 55% of patients with relapsed refractory DLBCL responded to blinatumomab. So clearly showing that bispecifics have a potential in the treatment of diffuse large B-cell lymphoma patients. So to show you more recent data, I want to show you the data for mosunetuzumab. So what is mosunetuzumab? It's a bispecific antibody that binds CD3, so again, the T cells, and binds CD20. And by bringing, and I didn't mention that before, this T cell to the tumor cells, T cells get activated and kill the lymphoma cells. So these are the data for patients with aggressive lymphoma. This was a very large phase 1 study, and you see the different schedules for this bispecific antibody, and you see that overall for heavily pretreated patients with relapsed refractory disease, the response rate is roughly 40%, so this is quite good. The CR rate is 20%, and many of these, especially CR patients, are in remission for a long time and potentially even cured. And it also works after CAR T cells. I mean, it's only a small number of patients that were included in this analysis, but some of these patients still responded despite being failure to CAR T cells. So with that, I want to conclude. I hope that I was able to convince you that R-CHOP-like therapy, at least up to now, remains the standard of care. I believe in young, low-risk IPI patients, therapy can be reduced, and this will not be affected by the POLARIX data. As I've shown you this press release, and we have to dig into the data into detail, obviously, when they're published, when they have been presented. However, the combination of R-CHP plus polatuzumab has the great potential of changing frontline therapy of diffuse large B-cell lymphoma patients, and this will be a dramatic change after essentially almost 20 years of therapy where we always used R-CHOP and had a plethora of failed treatments. I think up to now, again, high-dose chemotherapy and autologous stem cell transplantation remains the standard of care. However, I'm pretty sure it will change very soon, and I think CAR T cells will move up the chain, and they will be used as first-line therapy, or treatment of first relapse. We know that CAR T cells work in third line, and they have a curative potential. And we have, finally, as I've tried to convince you, many novel substances, specifically polatuzumab, which I have not shown you today because it's published for quite some while. It's approved for the treatment of relapsed refractory patients. We have a combination of tafasitamab and lenalidomide. We have bispecifics that are very efficacious. So I'm pretty sure that by combining these different regimens, different drugs in a very reasonable manner, that we will improve outcome of affected patients. With that, again, I want to thank you for your attention, and I'm really looking forward to the discussion. Thank you very much.